Good evening, family. How are you? It's your community doc coming to you on our Wednesday for our COVID-19 updates. I'm going to hop on my personal Facebook page to make sure that we are sharing it on there, because a lot of times folks come look for me over there. All right, so I'm put join us now. Done. Excellent. All right. I'm enjoying a little cocoa. It's been a cocoa. Hi, Heather. It's been a cocoa kind of day today. It's been a cocoa kind of year. A little, you got to get the dopamine released. It's the chocolates in a healthy way, right? Because if we eat sugar by itself, that certainly facilitates dopamine release, but I'm trying to do it in as healthy a way as I can. So I have some Ghanaian cocoa powder, some almond milk, and a little agave mixed in here for a little liquid magic happening. I wanted to make sure I jumped on time. It's probably one of the first times I've been on right at 9 o'clock. Lots going on. Hello, beautiful. Hello, Miss Worthy. How are you? A lot going on for me personally. I tried my best to protect my family in terms of how much of their business I put out there. Oh my goodness, I will definitely, Heather, I need to find out from Mika if she recorded it, but I owe you guys the PowerPoint. You already know, you may not have heard on Monday. So on Monday, I had the honor and privilege of speaking with a group of parents and caregivers of children and adults with Down syndrome. And we were specifically looking at how COVID is impacting children with Down syndrome. But really it started last week, where I spent some time talking with the folks over at HSC, which is Health Services for Children with Special Needs, HSCSM. And we were talking about children with developmental disabilities. We were talking about children with significant chronic medical issues, genetic disorders, etc. And sort of where are they within this pandemic. And one of the things that I mentioned last week, and again I mentioned on Monday, was how woefully deficient we collectively have been in terms of providing prioritization in for our children and really for our adults as well with disabilities. There's this term called ableism, right? And it's a real thing. It's the same thing as racism and sexism and homophobia. We really have to, particularly as those of us who are child health advocates, advocate for there to be specific focus on children who may have intellectual disabilities, who may have a collection of health issues. And it was just such a joy to spend time with parents on Monday, specifically talking about Down syndrome and the fact that we have to do a better job of paying attention to that population in terms of data collection as it relates to COVID, because children and adults with Down syndrome are at significant risk of having severe COVID-19 symptoms, as well as dying from COVID-19 because of some of the health conditions and genetic issues related to Down syndrome. So Heather, I owe you and the entire group a PowerPoint presentation to pair with the conversation that we had, so you didn't miss out on too much. And I'll try to talk through it and record it so that it'll be like you were there. But my PowerPoint, my computer crashed 4 times in trying to do it. And this was while simultaneously learning that a loved one had been rushed to the hospital because of difficulty breathing associated with COVID-19. So Monday was quite a doozy. So, but we still got through it. We still made it through. So I was very, very happy. I was very transparent. Y'all know me. I'm transparent in my processes. So at the start of it, I let folks know sort of what my mindset was coming into the session. But you guys welcomed me, you loved on me, you prayed for me, with me. And the praise report is that the loved one was able to get discharged home just on some oxygen, a little bit of oxygen, so and was able to get all the meds necessary. But I just want to spend a moment before we get into the, our usual regimen. I just want to spend a moment to acknowledge the anxiety And yeah, if anyone, I so wish a lot of times that this was more interactive, because I'd be asking you guys these questions. The anxiety associated with learning that a loved one has COVID. Woo! I don't want to spend a whole lot of time on it because we'll be crying for the whole hour. But the anxiety, the panic, the desperation, like as a physician, I know maybe a little bit more than most folks, but as a human being, as a daughter, as a granddaughter, as a niece, as a cousin, etc., the minute I hear that one of my loved ones has COVID, especially when I know, we collectively know the risk when it comes to chronic diseases, when it comes to our older population. So the minute you hear so-and-so has COVID, you lose your breath for a minute, and your mind, because we're human, it automatically goes, at least for me, it goes to like the stats. Like if she gets it, the likelihood of her surviving it is X. And I'm a woman of faith. I believe in prayer. I believe that God is the ultimate physician and he has the ability to heal, to do all of those things, but I'm also human. And so part of me throughout the past 2 weeks, it's been a roller coaster in terms of where I am in my emotional response, where I am in terms of connecting spiritually, because I have to protect those who have gone through this process. I can't say too much about what's been going on with my family, but just know that you are not alone in the experience of the anxiety when you hear about a loved one fighting COVID. And I pray for each and every one of you, as they say in the church, every one of you under the sound of my voice, not only in terms of the coverage for your family, but the coverage for each of us in terms of mental health. It's incredible to me how paralyzing it can be when you hear about one of your loved ones being diagnosed with COVID, and then to hear that they're being rushed to the hospital. Like your mind just goes to all the dark places. And I just want us to really just spend just a little bit of time acknowledging all of the different mental, emotional, spiritual even aspects of this pandemic, particularly for most of us who have likely had at least one loved one who's developed COVID. And there's, it's no rhyme or reason to it. Just because someone is 20 and otherwise healthy does not mean that you still don't have at least a little bit of, okay, as the 2 weeks go by, like they hit that first week and you're just like, all right, what is this next week going to bring? And then they get into that second week and you can finally feel like you can breathe. And so I finally, for a good number of my loved ones, I feel like I can breathe. But there are a couple of them where I'm still like, all right, Lord, I'm fasting and praying. One of the beauties of COVID is that it certainly has strengthened my prayer life, and it has certainly strengthened my faith. So I wanted to be fully transparent in how I went through all of that, so that if you're feeling anxious, the Bible says be anxious for nothing. I'm striving towards reaching that. I haven't gotten there yet, but I give myself a certain amount of time to sort of sit in that panicked, anxious space. And then I start pulling out my praise songs. I have my little prayer circle that I tap into, because none of us can do this on our own. So I just wanted to make sure I put that out there for everybody, to understand that you're not by yourself if you have gone through that same emotional roller coaster. All right. So you know how we do. Usually I start out with the numbers, but every once in a while I follow the Spirit, and the Spirit led me to put that out there for you guys, so that you know that you're not by yourselves if you go through these same processes. All right. So you know what we do. We go through the numbers first, and then we look at the trends. We look at the metrics in terms of seeing where we are in terms of the pandemic. And then we'll go into, I'll likely, as we progress through the pandemic, initially I talked a lot about symptoms and transmission and prevention. We are in it, and those things are still important. But as more conversations happen around, particularly the vaccines, vaccine safety, concerns, the myths, the truths, etc., I'll be spending a little bit more time focusing on those as well. All right. So let's talk numbers. From a global standpoint, we are now at a little over 115.5 million individuals who've now acquired COVID-19. When we look at deaths globally, we are now at a little over 2.5 million people who have lost their lives to COVID-19, and we're still consistently around 2.2% in terms of global death rates. And I always have to make sure I put my air quotes up in terms of recovery from COVID-19. We now have a little over 91 million individuals who have recovered from COVID-19. That puts recovery at close to 80% globally. We are now sort of classifying individuals who have ongoing COVID-19 symptoms as long haulers. I'm sure there will be other names for them as time progresses, but those are for individuals who have developed brain fog, symptoms similar to chronic fatigue syndrome. And we'll talk a little bit about brain fog because some scientists have figured out with some data that they've looked at the possibility of why brain fog is happening. So we'll talk about that a little bit when we get into symptoms, all right? Our national numbers, we are now at close to 29.5 million individuals having acquired COVID-19. We are now a little over 530,000 individuals who have lost their lives to COVID-19. The death rate between last week and this week has increased. It was at 1.6% last week. It's now at 1.8%. We're still seeing death rates declining. The reason why we're seeing this death rate increase, it's a matter of fractions, right? So as we've talked about over and over again, the way that they calculate or we calculate the death rate is of the people. The denominator is of the people who have COVID-19. The numerator is how many people have died. Well, the challenge is testing has gone down. We've seen reductions in testing across the country by around 500,000 tests. We're less than our testing is decreased by 500,000 compared to just last month. And so when you have less people testing for COVID, the denominator gets smaller and then the total fraction or percentage gets bigger. So I want folks not to panic thinking that more people are dying. We're actually continuing to see decreases in deaths related to COVID, but the decrease in deaths has significantly decreased. And that's a lot of decrease in one sentence. All right. In terms of recovery, close to 20 million people have recovered from COVID-19 here in the U.S. Again, in quotes, because we know of the long-term complications from COVID-19, even with minimal symptoms. And as we've talked about before, there have been a variety of apps that have been pushed out so that we can continue to track individuals who have survived and hopefully are thriving through COVID-19. So those are our numbers. I want to make sure I don't miss any questions about the numbers. Thank you guys for your encouraging words. I so appreciate you. I appreciate you guys. All right, so let's talk about our metrics. You guys know, you are my budding epidemiologist now, that there are two metrics that we look at. The average number of, the daily average number of new cases, with a goal being less than 25 new cases per 100,000 residents so that we can compare apples to apples from state to state. And then our second metric is our percent positive. In terms of the daily average number of new cases, we are doing fairly well, all right? So before, there were 11 states in the red zone, meaning they had greater than 25 new cases per 100,000 residents. We now have 10 states in the red zone. So slowly but surely, we are making some progress. In terms of the states with the highest number of new cases, those include Rhode Island. I don't understand. Rhode Island keeps going up and down, right? They have consistently, for about a month, maybe even 2 months, been in the top 5. And I'm not quite sure why. When we know states like Maine, Vermont have been doing I can't even say a decent job. They've been doing a great job in terms of reducing their COVID-19 numbers. I'm not quite sure why, as small as Rhode Island is, they are now averaging 56.8 new cases per 100,000 residents. That's up from last week by about 15 cases per day. So Rhode Island, I need you to get it together. New York and New Jersey are in positions 2 and 3. They are also the states across the country that have seen a steady increase in terms of their COVID-19 cases. New York is now at 38.4 new cases per 100,000 residents. Jersey's right behind them at 37.8. South Carolina and Arkansas top out the top 5. I'm going to bring Texas up only because Texas is in the red zone. The governor made a decision just yesterday to open up the state and simultaneously remove the mask mandate, even though they have not yet met the metric of having less than 25 new cases per 100,000. Mississippi is in the yellow zone, but I'm still going to fuss at them because they should have maintained, like, open it up, but don't take the mask mandate away, right? Like, open up. I'm all about free enterprise. I'm an entrepreneur myself, and I fully understand the impact that COVID-19 has had on the economy, but death from COVID also has an impact on the economy. And so it just sometimes it makes me scratch my head in wonderment and trying to figure out how some elected officials make these decisions, especially when the public health professionals in Texas are like vehemently fighting against what the governor is trying to do. So that's where we are in terms of daily average number of new cases. In terms of percent positives, we're noticing a decrease in terms of the number of states with percent positive tests. But again, as we've talked about, we have seen a decrease in testing across the country. And the issue is whether or not people are presenting to be tested because less people are significantly symptomatic, or is it that more attention is being focused on vaccine strategies as opposed to testing strategies? But we are American. You know, we can walk and chew gum at the same time. So we certainly should be able to test while we vaccinate. Right now, we have 19 states that are at 5% for 5% positive testing or higher. And it's the top 5 states have been the top 5 states for the past month. Idaho, South Dakota, Kansas, Iowa, and Alabama are all testing percent positive in the double digits between 17 to 23%. I want to mention Texas and Mississippi because the benchmark is to test at less than 5%. Texas positive percentage rate is 12.3%. and Mississippi is 14.9%. So if states are using evidence to base their decisions on reopening and removing mask mandates, at minimum, these two metrics should be used: the daily average number of new cases and the percent positives. And for neither state have they met the percent positive recommendation as put forth by the WHO. So there you go, Mississippi and Texas. I'm hoping, my fingers are crossed and my breath is holding to see what Florida does, because you guys know spring break is right around the corner, and they suffered some financial impact from last March, relatively being shut down, right? But we all saw the pictures of our young people out wilding out during spring break. I would imagine we're going to see something very, very similar in Florida this spring break, because our numbers appear to be coming down, all right? All right, let's see. It will. All right, so now let us talk about the trends, all right? So in terms of new cases, we are definitely going down in terms of the average number of new cases. Again, this is sort of with an asterisk next to it because we have reduced testing. We were last week at around 68,000 new cases per day. We are now at close to 58,000 new cases per day. Last week, we had decreased the new case percentage by around 30%. We are now down, but not as much. So we're down around 23% in terms of the number of new cases. As I mentioned just now, New Jersey and New York are adding cases higher than any other state in the union. And, you know, as we talked, heard from Governor Cuomo talking about opening up restaurants and other facilities. We have to pay attention to the numbers, because when we open up too soon, this is what happens. So going from February through the summer, right? We had our peak and then we plateaued and started to come down. And then the summer, everyone was, enjoying the sunshine, getting together for 4th of July, summer parties, etc. The numbers started to creep up a little bit. And then we went into the fall, right? Where the numbers continued to go up. And then we were here in the winter time and the numbers shot up. The challenge with reopening too soon is that when we plateau this time, the baseline number of new cases is higher than it has been when we've plateaued before. And so it's almost like when you turn a fever, right? I think about it in terms of a fever. If a little one has a temperature of 99, right? You've given them some fever reducer. Their temperature was initially 104. And you bring their fever down to about 101. And then you layer them up with clothes because it feels chilly in the house. What's going to happen, because you didn't allow the temperature to normalize, is that you put the little one at risk for their temperature to go up even higher because you stop them around 99, 101, right? But if you wait and let the temperature come all the way down to baseline, and then you want to layer your little one up because you feel like it's chilly in the house, it's less likely when they have a fever that their fever is going to shoot up significantly higher. The same thing with COVID. If we start at a higher plateau than we did before, that means cases shoot up even higher, hospitalizations go even higher than they have before, and deaths happen at a higher number as well. So when you hear people say cases are coming down, deaths are coming down, hospitalizations are coming down, but if we do not approach this cautiously, we will see the worst of it over the next couple of months. You're like, that doesn't even make any sense. Like, the worst of it was in January, except we would be starting our baseline at a higher number than previously. So that's where, when people are making these projections about even higher numbers compared to past COVID-19 experience, that's where they are coming from. So we really want to be able to bring the baseline number of COVID-19 cases down as low as we can. The way that we do that is continue to do what we're doing. We continue to mask up, socially distance, keep things limited. I'm not saying a complete shutdown, but keep things limited in terms of large group settings until the numbers come down significantly, either through our public health measures or through vaccination measures. You know, we're likely to reach herd immunity with the rate of vaccinations that we're doing sometime in the fall. But if we misstep and hit the gas in terms of accelerating towards reopening, what we will end up doing is not just stopping all the progress that we have made since January, but positioning ourselves in a worse space than we were prior to the holiday. So if you hear some epidemiologists, other public health folks talking about us potentially being in a worse position, that's the reason why. And then you add on top of that variants that cause more infections at a higher baseline. Oh my goodness, you talk about a tidal wave. So that's why a lot of us are still in our feelings completely about what Texas and Mississippi have done and what we anticipate other states to be doing sometime soon. I can almost guarantee Arizona, Florida, and Georgia are soon going to follow suit in terms of following the work of Texas and Mississippi, despite what the scientists say. But that's what happens when you focus, when priorities are different. That's all I'll say about that. When people's priorities are different, then you get these decisions being made, all right? So let's talk about hospitalizations. I'm happy to say that we are down in terms of hospitalizations, another 10,000. We have almost 30% less people in the hospital this week than we did last week. So our first line healthcare workers I can't even say they get a sigh of relief. It's still a lot of work, but at least we give them some space to breathe a little bit, right? In terms of deaths, as I mentioned before, we're averaging lower deaths now than we were even just last week. We're now averaging around 1,300 deaths over the past several days. We were seeing a decrease in deaths last week at around 23%. The decrease in the number of people dying from COVID has slowed down. So we saw a 23% decrease in the number of people dying from COVID last week. Now it was only a 9% decrease in terms of the number of people who have died from COVID-19. So we have to be very cautious as we move through reopening so that we do not reverse that trend and end up inundating the healthcare system. You look at a place like Brazil. Hold on, let me get a sip of my delicious cocoa. Carrie, I'm going to answer your herd immunity question. I think that's a very important one. Part of it I'll answer as we talk about Brazil. So one of the issues in terms of the vaccine and in terms of herd immunity, right, is that we need to reach herd immunity, meaning you reach herd immunity by one of two ways. Either allowing everyone to be exposed and everyone to get COVID-19, or by attempting to vaccinate at least 70 to 80% of your population. I brought Brazil up for two reasons. One, COVID-19 in certain parts of Brazil has run so rampant that subsegments of the population, they are close to reaching herd immunity simply because of the infection. In Brazil, certain parts of Brazil, it has gotten so bad they have run out of oxygen. Like, physicians, nurses, families have been devastated watching loved ones suffocate to death because there was no oxygen available. This isn't, in Brazil, recently has had a pretty developed economy. So it's not like Brazil is the Brazil of the 1990s. But today, people have lost their lives because Brazil, in certain parts of Brazil, they've run out of oxygen. They've run out of hospital beds. They've run out of capacity to take care of people. And the infection has run so rampant that certain parts of Brazil, they have reached herd immunity simply based on the infection itself. No society, no population should reach herd immunity based on the population being exposed to the virus and allowing it to just do what it's going to do. The goal is for us to reach herd immunity by, here in the US, it'll likely be a combination of individuals who have had COVID-19 and the majority of people who have received the vaccine, right? Because if you think about it, 70 to 80% of our population is around 280 million individuals. We're at 28 million in terms of COVID-19 numbers. So there is lots of wiggle room for us to be able to vaccinate the majority of our population in terms of reaching herd immunity. So that's the goal, is to get vaccinated. We usually talk about herd immunity in the context of vaccinations. As a public health professional, I have not ever seen a society allow an infectious organism to run rampant, and that's how the strategy is for the population to reach herd immunity. And I don't think that Brazil planned for that either. Is that they were just overwhelmed by COVID-19, and the vaccine rollout has been very, very challenging for them out there. So that's one of the reasons why we're seeing what we're seeing in Brazil. Let's talk a little bit about transmission in terms of the mutant strains. I think that's going to be a very important topic to continue to stay on top of as we progress through the fall, as hopefully more of us get vaccinated. We now know of the 3 mutant strains out of South Africa, Brazil, and the UK. There are now 2 strains that have been homegrown here in the US, one in California and one in New York. The one in California spreads more readily than its original version. If you guys remember at the beginning of the pandemic this time last year, New York and California and Washington, those were like the 3 states initially hit very, very hard when COVID-19 arrived here in the States, right? If you believe that it started in February, folks are still saying this was here back in December of 2019. I'm not going to argue. But what we do know is that this strain is more infectious than the original strain that arrived in California based on research. But what studies have now demonstrated is that it is not more infectious than the UK strain. All right, I think that's important to know. And then there were some initial reports last week that it may be more deadly, but there's very, very weak evidence. There has not been significant evidence to support that the California strain is any deadlier than any of the other strains, but we're still collecting data, right? The New York strain is potentially a little bit more concerning than the California strain because they're feeling like it may be more infectious than the California strain. There has not yet been any data to demonstrate that it is any deadlier than the California strain. We also know that there are 2 mutant strains coming out of India, and this is why, again, this is a global pandemic. That's why it's a pandemic. And what happens in one country can affect the rest, right? So that's one of the reasons why collectively we have to monitor these mutant strains. It's one of the roles of the WHO, and I'm just so grateful that we are now back part of it, all right? One of the other things I want to note is that for all of these strains, although they have all been identified as potentially more infectious, none of them to date have been confirmed to be deadlier, all right? We're still collecting data, looking at numbers to do a comparative analysis. But that's the reason why vaccinations against the virus are so important. And someone asked a question a couple of weeks ago. A friend of mine asked the question, why is so much of the focus on vaccines versus treatment, right? So when you think about public health, we have various levels of prevention. There is primary, secondary, tertiary, and quaternary prevention. I won't get into all of them, but primary prevention, the goal is to prevent you from developing whatever the disease is, whether it be heart disease, diabetes, infection from COVID. And vaccines are at the heart of primary prevention. I don't want you to get COVID and then have to treat you from COVID if there is the capacity to prevent you from having either severe symptoms or coming close to dying. I don't even want you to have to need treatment because I don't want you to be in a space where you become that ill, right? So although we do not yet know how well the vaccine prevents you from getting COVID once you've been exposed, what we do know is how well these vaccines work once you are exposed in terms of decreasing the risk of severe symptoms and reducing the risk of death. We are in the middle now of conducting studies to answer that question. We could not ethically just expose people to COVID who had received the vaccine and those who had not received the vaccine, because remember, this is a double-blinded, randomized controlled trial. We don't know who got what. But to just voluntarily expose people in the phase 3 trial to COVID is unethical. But now that individuals who know that they've been vaccinated, we can consent for them to knowingly and willingly be exposed to COVID to determine how well the vaccine protects us from acquiring it and from transmitting it. Those studies are being recruited for now, and we will have an answer to that question likely by the fall. So stay tuned, all right? But I want to make sure that we are very, very clear on the role of all of the vaccines we now have available to decrease severity of disease and to decrease the risk of death. The question still remains to be answered, how well it prevents an individual from developing the infection once exposed and preventing them from transmitting the infection once they develop it, all right? So those are the questions that still remain. In terms of where we are when it comes to administration of the vaccine, we are now at 16% of the population having received at least one dose of the vaccine, a total of close to 53 million individuals. In terms of those who have been completely vaccinated from COVID-19, we are now at 8.1%. We are getting close to 10%, y'all. It's almost time for Dr. Hancock to roll up her sleeve because you know my threshold is a sample size of 10%. So 27 million people have now gotten both doses of the COVID-19 vaccine. The updated information is Johnson & Johnson has received their emergency utilization authorization approval. Yay, J&J. I read a meme somewhere. They said, how can you trust a vaccine created by a company where you couldn't trust their baby powder? Well, it's again based on evidence, right? I'm not going to argue the meme, but what I will do is pay attention to the study results that they provided to us. We talked about it a little bit last week, but I want to reiterate sort of how this particular vaccine works. The Pfizer and Moderna vaccines are based on mRNA technology. So instead of giving you a piece of the DNA or the genetic material of the spike protein, they give some instructions in terms of how the body can make the spike protein. The DNA vaccine that Johnson & Johnson has created is very similar to previous technology or previous vaccines that have been created. Very similar technology to the rotavirus vaccine for anyone who has a little one who got the Rotatech, which protects against the rotavirus infection that it's the most common cause of infectious diarrhea among children here in the U.S. It was also the vaccine that has been used, the vaccine technology that has been used for the Ebola virus. So that's the good news. But the technology, like using the adenovirus, this is how the sort of the channel by which the vaccine uses to introduce the genetic material into the body is through the adenovirus. It's a dead version of adenovirus. A lot of you know that the adenovirus is one of the most common causes of the cold. So they use a dead form of the adenovirus to use as a transport to allow the DNA from the spike protein to enter into the body. It does not enter into your own DNA. It will not interact with your own DNA. All it does is facilitates the creation of spike proteins, a small amount of spike protein, so that the body will recognize it, create an immune response to it, and then the DNA from the vaccine is broken down over several days after our bodies have mounted immune responses to it. One of the other benefits of the Johnson & Johnson vaccine is that it's more durable, if you will. The mRNA within the Pfizer and the Moderna vaccine are kind of fragile, which is why you have to sort of package it with some lipids and some salt and some sugars to maintain the pH, so that the pH balance is maintained and the mRNA does not break down. The lipids allow it to enter into the body so that the body will not immediately break it down. It allows like a little bit of a channel. The other good thing is the DNA is not as temperature sensitive, so you can store the Johnson & Johnson vaccine in the refrigerator. I know that there were some concerns about the efficacy of it. The efficacy is around a little over 60%. Better than most of our flu vaccines annually, if I'm honest with you and myself, but I still get the flu vaccine because I figure some protection is better than none, right? With their study, they studied over almost 44,000 individuals across the globe. They studied individuals in the United States. They studied individuals, I want to make sure I get it right, in South Africa and in Latin America. In the U.S., it actually showed better efficacy than in those other countries. 72% efficacy in the United States in protection against severe symptoms. And there was an 85% efficacy in terms of looking at protection against severe disease across all countries. So for the Johnson & Johnson vaccine, certainly when it comes to protecting us against severe infection, it was 85% effective, just so that you guys know. I know a lot of the focus has been on the overarching efficacy of the vaccine, but in terms of protecting against severe infection, it's actually done a really good job. The other interesting thing that we have not heard a lot about is protection, or in terms of the side effect profile. With the Johnson & Johnson vaccine, there were very few severe adverse events. It was actually, the severe adverse events were actually higher in the placebo group than there were in the vaccine group. There were some concerns I've seen in the media recently about aborted fetal tissue being in the vaccine. I just want to make sure that I address that. So historically, decades ago, aborted fetal tissue was used in the creation of vaccines. The vaccines that are created now, specifically these DNA vaccines, these are cloned cells from this original aborted fetal cell line. I'm not going to get into whether or not you should feel comfortable with that or not. I just want to make sure that I explain what that means. It's not like they're using fresh aborted tissue to create these vaccines, but you will decide based on your religious principles how comfortable you feel with it. The challenge is when you show up to get a vaccine, it's not like you get to pick between the ones that are available, all right? One of the other questions is, how well are these vaccines working against the variants? I'm happy to report that for the UK variant, Pfizer and Moderna are working very, very well against the variant. AstraZeneca has had decreased efficacy against the UK variant. Their efficacy is around 74% against these variants, 84% against the original COVID-19 where the vaccine was based. In terms of the South African variant, for both Moderna and Pfizer, they provide data that demonstrates there's still a very good antibody response, but they did note that there was a slight decrease in terms of the immune response to the South African variant. And Johnson & Johnson reports that their efficacy with the South African variant went from 72% here in the U.S. down to 57%. So that is something to be a little bit concerned about. I want to spend a little bit of time addressing myths. Today I had the privilege of connecting with the Maya Angelou School out in Washington, D.C. I was asked to address COVID-19 vaccine myths, truths, and facts. Say that fast 5 times. I will do a separate video talking about the COVID-19 vaccine myths, but I just wanted to address the ones that I get asked the most often. The first is, will the COVID-19 vaccine affect fertility? This is a question I've been asked probably at least 15 to 20 times. And the answer is no. So there was a social media post pushed out that said that the spike protein targeted by these vaccines was the same spike protein that our bodies use, that the female body uses for the placenta to attach to the uterus. That's not true. They just so happen to both be called spike protein, but they are not the same protein. So the vaccine and the antibodies generated from the spike protein related to COVID aren't going to attack your uterus, your placenta, if and when you decide to get pregnant. Hold on, I feel a tickle. So the other thing I want you guys to know is that 23 women who received the vaccine in the Pfizer study got pregnant after they got the vaccine. So there you go, right? Two completely different spike proteins, and women got pregnant after they got the vaccine. And there was only one woman who experienced a miscarriage during the vaccine trials, and she was in the placebo group. So this is, one of these examples where you want to vet it before you spread it, right? Simply because I'm sure what happened was somebody Googled spike protein, and on the third Google search page, there was some mention of spike proteins related to placental health and pregnancy. And they were like, oh, see, there's the spike protein they're talking about. It does cause infertility. Different spike protein. And clearly, as time progresses and more data is collected, I know better than to say that 100% I'm sure that it does not cause infertility. But what I can tell you is that the social media messages pushed out about these being the same spike proteins is wrong. What I can also tell you is that women who received the vaccine in the phase 3 trials went on to have healthy babies. So there you go. Now, the next question that I get is, when you get the COVID-19 vaccine, don't you get sicker than if you got COVID? And aren't you at increased risk of death from getting the vaccine than you are from COVID-19? And there was a video that Sharice sent me. It's a nurse practitioner. And I think this is where it gets really, really confusing, right? When you have healthcare professionals espousing some of this stuff, it gets very, very hard to decide, is this truth or is this fiction? What I will tell you is that anyone who speaks on this must revisit their biostats class. You have to be able to critically analyze data before you can speak on it, because, and I'll break this down when I do my whole video on addressing the myths, but one of the issues that she raised was deaths related to the vaccine. And she said that there was one death in the Pfizer study, and then there have been a lot of social media messages about there being 6 deaths in the Pfizer study, and that this is why you should be careful because the vaccine kills you. In actuality, with the Pfizer study, there were 6 people who died in the Pfizer study. 4 of them were in the placebo group. So when you think about statistics, and you read, and it's right there in black and white on the paper, clear as day, that 4 people in the placebo group died and 2 people in the vaccine group died. So clearly there was more risk of death in placebo, if there was such a thing, right? And then I think someone posed the question, why would they kill people in the placebo group? And then someone else speculated, well, they wanted to hide the fact that people were dying in the vaccine group, so they had to make it seem like there was risk of death in the placebo group as well. And I always tell folks, when the story sounds very far-fetched, you have to ask yourself, does this make sense, right? Does this really make sense? And one of the things that we also want to pay attention to is ongoing data collection. We now have close to 60 million people who've received at least one dose of either of these vaccines, an additional 27 million people who've now received both. So you're looking at over 80 million doses of COVID-19 vaccine being administered. And of those, there have been 800 deaths reported among individuals who have received the vaccine. And I want to make sure that I say that clearly. There have been 800 deaths reported among individuals who have received the COVID-19 vaccine. That does not mean that the COVID-19 vaccine caused these people to die, right? Correlation does not equal causation. Just because they got the vaccine and they died doesn't mean the vaccine caused them to die, right? If a person got the COVID-19 vaccine and then within a week got into a car accident, it does not mean that the vaccine caused them to wreck their car. And even if, and I'm going to say this as a comparative analysis, but I don't want you guys to say, well, Dr. Hancock said there's a death rate associated with the vaccine. If we were to calculate a death rate associated with the vaccine, 800 people there have been 800 reports of death of individuals who have also gotten the COVID-19 vaccine among 80 million doses being given out. And so if we add up, if we just look at the 57 million people who've only gotten one dose, 800 divided by 57 million individuals would put the vaccine-related death rate at 0.002%. If that was such a thing, which it isn't, but I just want to make sure we can do apples to apples comparison. So if we were to calculate a death rate associated with the vaccine, 800 people have had death reported in those who've received the vaccine. Of the 57 million people who've received the COVID-19 vaccine, that would put them at a death rate of 0.002%. What we know is the COVID-19 death rate is today it's 1.8%. 1.8% compared to 0.002%. How can anyone say that more people are dying from COVID vaccine than they are from the virus itself? From a mathematical standpoint, it just doesn't make any sense. All right. So that's what I want us to think about. I want to talk a little bit about vaccine acceptance. That has been a conversation that has been happening a lot. It's been more titled vaccine hesitancy. I like to place it in vaccine acceptance. One of the conversations that I had with the school team today was this whole notion, particularly of communities of color being hesitant around receiving the vaccine. One of the things that I said was, when you call communities hesitant about getting a vaccine, it puts all the responsibility on us in terms of making the decision and not really paying attention to the systems that have been created in which we are making these decisions, right? When we think about the historical context of science and medicine and the present day context of science and medicine as it relates to communities of color, particularly Black people, we don't have to just go to Tuskegee as a reason why we are hesitant or delayed in our acceptance of the vaccine. We can think about instances just yesterday for some of us. When we think about Dr. Susan Moore, who I've talked about before, because of mismanagement of COVID for her, she ended up losing her life. There are numerous examples of this that I can go on and on about, and it isn't just Tuskegee. I mean, when people talk about Tuskegee, it's as if Black folks don't have any current day reference points as to why we have a distrust of the medical system. We have ample examples in 2021. I can give you examples in February of 2021 as to why we can collectively still raise our eyebrows when it comes to science and medicine. But the interesting thing is, as much as there's a conversation, particularly around African Americans being hesitant around getting the vaccine, data speaks something different. The Kellogg Foundation just released a report looking at the perception of African Americans related to the vaccine. One of the pieces of data was that older African Americans are actually more open to getting the vaccine than their white counterparts by like a difference of like 10%. The issue is access, right? And then looking at African Americans, Latinx communities, and whites across the country, when they were asked, what are the reasons why you are not signing up to get the vaccine? For as many people of color who said that they were leery of the science, the same number said, I'm afraid to get the vaccine because if I get sick after I get it, I won't be able to go back to work. Same percentage of people. The other same percentage was, I'm not sure how affordable the vaccine is going to be. They say it's for free, but how do I know I'm not going to get billed later? And this is rooted in a distrust of the system because of how we have been treated. And so as much as people want to use Tuskegee and historical context as an example, one, we have present day examples, and two, we're as equally concerned about how receiving the vaccine is going to impact us economically, job security, and then they also want to be able to find a safe and trusted space to receive the vaccine. Once those are addressed, I strongly believe that more people of color will be open to getting the vaccine. So those are just my 2 cents. I want to give you guys a quick update on children and the vaccine. Moderna and Pfizer have fully enrolled their vaccine studies. Pfizer has 2,000 children enrolled between the ages of 12 and 15. Moderna has 3,000 children enrolled between the ages of 12 and 17. They're anticipating having the studies done by the summer and a vaccine for children in the fall. The reason why they aren't recruiting as many children as they did adults is we know the vaccine works. Right? We know the immune response that's triggered. The question for children is, 1, what is their level of antibody response? And 2, are there side effects that children may experience that grown-ups do not? Children are not just little adults. They are children. And so we have to make sure that we're paying attention to how their little bodies respond to the vaccine. One of the questions that we raised at my conversation that I had with parents and caregivers of children with Down syndrome on Monday is that children with Down syndrome as young as the age of 16 have now been identified within the CDC as of December as a high-risk population. So make sure that if you know of someone who has a child or an adult with Down syndrome, or you have a child or an adult with Down syndrome, that they should be part of the high priority category. Pfizer and Moderna are looking at doing studies in the summer for children between the ages of 6 to 12. Johnson & Johnson is actually looking at doing studies from 6 months old through pregnancy. And Johnson & Johnson has been the only company thus far to talk about testing the vaccine on children as young as 6 months and purposefully enrolling pregnant women within the next couple of months. So we'll see what ends up happening with them. AstraZeneca is also doing a study looking at children with only 300 children in the UK. So I don't know how comfortable I feel with only 300 children being part of a study. I don't think that that's a sufficient sample size, but they didn't ask me. I'm just hoping that when it's time for our little ones to get vaccinated, that we have plenty of Pfizer and Moderna to go around, because the AstraZeneca one is still getting the side eye. So let's talk a little bit about return to school before I wrap up. I want to spend a little bit of time there because, especially as we're talking about opening things up, there are specific parameters that the CDC and the American Academy of Pediatrics has laid out in terms of schools reopening. But part of the conversation that I had on Monday with parents and that I had with the school system today are issues of equity, right? So when we talk about putting all these measures in place for schools to open, it's assuming that all schools are created equal and that all children will have equitable access to all of the provisions necessary to open a school safely. So that means universal mask wearing. And for the most part, I believe children will likely have access to masks. But it's also school spacing, right? Will all schools have the capacity to separate children by at least 3 feet, if not 6 feet? I can guarantee you that there are schools in each state, within each city, within each county, who will be better set up to separate the children out in terms of social distancing than others, which then puts other children at a disproportionate increase in risk. And we talk about baseline stuff like having soap and water, right? There are some schools that have never had an issue with hygiene products. They've always had soap. They've always had warm flowing water. There are children who attended schools across this country who did not have access to the basics like soap, water, and paper towels. And so how do we address the equity that needs to be dealt with as we get ready to bring our little ones into school? And there was just a report out last week talking about ventilation systems and how not enough attention has been paid by the CDC to require ventilation systems to be addressed. HVAC systems, like they said, we suggest that you enhance your ventilation systems or perhaps just open up windows. But then we also have to take into consideration school safety environments, right? I taught elementary school before I went to medical school, and we had something called Code Charlie Brown. Code Charlie Brown was the alert when there was a gunman on campus. I can tell you that twice when I taught elementary school out in Watts in Los Angeles, we had Code Charlie Brown. So we can't just keep windows open when there is the threat of school shootings and trying to secure safe school environments equitably for all children. These are conversations that we as adults, we as parents, we as educators, we as just good human beings, even if you don't have kids, these are conversations that we need to have so that all of our children are equitably protected when we get ready to go to school. And the other part of it is what we do as adults in terms of protecting our children. That's why these accelerated attempts to reopen entire cities and states are going to put our little ones at risk. I'm all for our children going back to school. My goal over the next week or so is to partner with a colleague of mine to push out an op-ed about it. I think it's important for our children's psychosocial development, for their educational development, for their mental health, for them to be able to go back to school. But what I also know, particularly for Black and brown children who are already disproportionately impacted by inequities in the school system and disparities related to COVID, that those gaps will continue to widen if we do not do right by all of our children in an equitable fashion. So that's my story, and I'm sticking to it. Let me see what questions I may have missed before I wrap up. All right, I'm gonna scroll up, get my squint on to make sure I haven't missed anything. All right. Let's see, and you guys feel free to ask me any questions that you may have. I know we covered a lot of material in the past hour. All right. Let's see. Scrolling. We talked about, I just saw the second part of Kara's question in terms of herd immunity. I think I answered it in terms of vaccinations versus infections, right? So one way or another, we're going to reach herd immunity. Either we're going to be like Brazil, and a lot of people are going to get infected, or we will do what we need to do in decreasing transmission, so we decrease mutations, and more of us become comfortable with getting the vaccine. That's how we're going to be able to get ahead, all right? Let me make sure I haven't missed anything else. You guys were quiet tonight. I know I did a lot of talking, but I really wanted to make sure that we covered especially the myths, because as more people are going to get vaccinated, you're going to hear more and more stories, even within the media. The media is notorious for reporting out the negative, right? So there have been, rare cases of Guillain-Barré, Bell's palsy, etc. But based on news reporting, you would think that a good number of people have acquired or developed these complications. What I want you guys to do, and I'll make sure to post it, is to go to the Vaccine Adverse Event Reporting System. That's going to give you all the numbers you need, right? And again, remember that part of the reporting out is from healthcare professionals whose patients report these issues out. There's also the app called vSafe, where this data is also available online through the CDC, where that's self-reporting. But keep in mind, in the same way for Tylenol, for any medication that you take, there's a laundry list of issues that can come up, right? If I get a little twitch in my eye after I get my COVID-19 vaccine, I may report that out. It could just very well be the stress that I'm experiencing, but because there's some correlation in time, people will feel it necessary to report that stuff out. It doesn't mean it's the wrong thing to do. Just the more data we collect, the more we can pay attention to some of the concerning things. And again, we do pay attention to that. If more people are reporting out Guillain-Barré, Bell's palsy, etc., and we're monitoring it, and it's higher than the rate in terms of the general population, those are the reasons why we collect that data, all right? When will vaccines be available for children under the age of 16? That's an excellent question. So they're anticipating that by late summer, early fall, Pfizer and Moderna will have vaccines for children between the ages of 12 up through 18, depending on the vaccine. So we will have vaccines available for 12 to 18-year-olds through Moderna and 12 to 15-year-olds through Pfizer. So if schools decide not to open up in the spring and instead they open up in the fall, what I imagine is a strong push at the end of the summer, beginning of the fall, for children to receive the COVID-19 vaccine. For little ones less than 12, it won't be likely until the winter of 2021 or the spring of 2022 that children between the ages of 6 and 11 will have access to the vaccine. For the little ones, from 6 months till, to 5, the question is risk versus benefit, right? Because you guys know, particularly as parents, there are a lot of vaccines that our little ones already get. And what we know from COVID-19 is that children less than 10 are less likely to acquire the COVID-19 infection once they've been exposed. They're also less likely to develop severe symptoms once they have an infection. That does not mean that children don't die from COVID, when we know that over 270 children have died. It doesn't mean that there aren't complications. We know that 2,000 children of the 3 million children who've had COVID have gone on to develop multi-system inflammatory syndrome. So it's not that children are immune to it. It's the question of, do we need to create this vaccine for little ones from 6 months to 5 years old? What is their risk? The challenge in answering that question is that little ones have gotten the short end of the stick. We have not sufficiently required states to collect pediatric specific data. Right now, in terms of case reporting, only 22 states report pediatric age-based information. In terms of COVID-19 hospitalizations, I believe a little over 40 states report out pediatric-related data. And in terms of COVID-19 deaths, only 43 states report out pediatric-related age-specific data. So we have to do a better job of our data collection to truly understand what this pandemic looks like amongst our children. On Monday, we talked about children with Down syndrome, them being at high risk both as children and as adults, and not having enough conversation around children and adults with Down syndrome in terms of them being prioritized and data being collected to determine truly what their risk is. Just, I believe it was last month, a study was published looking at children, or looking at adults with Down syndrome, particularly adults over the age of 40, where they were 3 times more likely to die from COVID than their counterparts. In the UK, they were 4 times more likely to die and 10 times more likely to be hospitalized. But a lot of that data we have not had. Like, what about children with sickle cell anemia? All of these other very specific diseases related to children, we have not done a sufficient job. And I'm hoping there's actually a conversation about there being the creation of a children's cabinet within the Biden administration. If anybody knows anyone in the Biden administration, let them know to call on me, because I'd love to serve on a cabinet specifically for and with. Hopefully children will be on it as well as us grown-ups. But it won't be until children have some representation, not just from parents, but from people who are directly connected, and children's voices, where these questions can be asked and the data can be collected, because children are finally prioritized even though they can't vote. All right? So, no, I hear you. I balance the concern that I have for my little one. Clearly, I pose at least some risk being a physician, but when I talked to my little one last week, she was in tears. She wants to go back to school. She's an only child. I can only be her playmate so many times throughout the week at recess and lunchtime play, because she's got an entrepreneurial mommy, right? I'm out here grinding, trying to take care of patients, attempting to save the world through medicine and public health. And so I'm not always available for her at recess as much as I want to be. And so it's heartbreaking to watch our children struggle. A colleague of mine, her child just flat out refused to participate in online learning. She had to go out and find a pod for her little one to at least have some form of school experience. And we've seen reports, we've seen news stories where children have become so depressed that they've either attempted or committed suicide because of the mental health stress that they've experienced being separated and disconnected from their social circle. So there is everything in life, I truly believe everything in life is a balance. It's the yin and the yang. So each of us has to balance the risk collectively and the risk individually for our children as we consider these decisions, all right? But we also have to talk to our children. One thing that I have noticed that we have not done in these conversations about returning our kids to school, we've heard from educators, we've heard from administrators, we've heard from the scientists. Have we talked to the babies? Have we asked them how they feel, right? Because there's a good portion of these babies who are going to be very stressed, very anxious and fearful about going back to school. We need to acknowledge where they are and how they feel and address their concerns. But we also need to talk to the little ones who are ready to go back to school so that they have voice, no matter how young or old they are, all right? Let's see. I want to make sure I don't miss anything. Excellent. All right, guys. Well, I held you over just a little bit because I wanted to make sure I didn't miss any questions. Do not hesitate to reach out, connect with me for any questions that you may have. I'm getting ready to re-release my website at the end of March with more health information. It's going to be bigger, more wonderful, more engaging, with a lot more information for you guys to be able to access. All right. Website is askdryola.com. I will see you guys this time next week, perhaps sooner, because as I mentioned, I do want to do a quick video addressing some of the top myths associated with the COVID-19 vaccine. All right. Love you. Can't wait to see you guys in person. Until next week. Mwah. Dr. Yola out.